Well, everyone, welcome to this CADIO webinar today. We are so excited to have Dr. Edward Watkins here with us. Edward Watkins is a professor of experimental and applied clinical psychology at the School of Psychology at the University of Exeter. He is a chartered clinical psychologist trained at the Institute of Psychiatry, specializing in cognitive behavioral therapy, and director of the Mood Disorders Center at the University of Exeter. His work focuses on the psychological understanding, treatment, and prevention of worry, rumination, anxiety, and depression using face-to-face and digital approaches across the lifespan. His research has been funded by the Wellcome Trust, UK Medical Research Council, European Commission, and the NIMH in the US. He currently leads a Horizon 2020 funded project to develop and test personalized digital self-help promote well-being in young people across Europe, and a large UKRI-funded project to develop and evaluate a step-change whole university approach to improve student mental health. He was awarded the BPS May Davidson Award in 2004 for outstanding early career contributions to clinical psychology, and he was an expert member of the recent UK NICE Guidelines Review Board for Treatment of Depression. So, Dr. Watkins, again, thank you so much for being here with us today.
Great, thank you. Can you hear me? Yes?
Yes.
Great. It's a pleasure to be here and nice to be talking to you. I'm not sure whether I get my mix right here. So obviously I'm going to be talking a bit about factorial trials and how we've used them in a psychological treatment context, but I'll also say a bit about psychological treatment and depression, because I think that's the context that's relevant. So I don't know how much this is a methodological audience or a clinical audience, but hopefully the mix will be of interest, because I know that a lot of the work in factorial designs has been more initially in the sort of health behaviors space. So this is trying to move it into a different group of people and a different set of interventions. And yes, as said, I'm in Exeter, and just a little picture I've got on the bottom of my slide. I'm using the old university logos. I don't know about your universities. I also always seem to be updating the logos every few years, but I actually quite like this one because it's got a picture of the cathedral, which is one of the more attractive bits of local architecture. Okay, and I'm just going to have to acknowledge all the folks that I've worked with and who've helped support this work, and the funders we've had for different bits of this work, and of course that includes folks on the other side of this call. So Linda was obviously involved in helping us design and think about some of this work, as you'll see later. And more specifically, this particular research was funded by Cornwall Partnership NHS Foundation Trust, which is a mental health trust in the southwest of England, and the Academic Health Science Network. So I'm just start with the broadest context in terms of the global challenge of depression. 1 in 5 people are likely to experience significant depression during their lifetime, which means it's these might be slightly a few years out of date, but the estimate there's at least 151 million people per year around the globe. It's a recurrent disorder. Many people have it more than once. Many people have it multiple times. It's clearly very disabling to the individual, with major personal cost, but it also has a huge disease burden in terms of quality of life, productivity. It's rated as one of the highest disorders for that, as a function of the both the multiplication of the prevalence by the impact of the disorder. And there's different estimates of economic cost, at least getting on for 100 billion per year in euros in Europe. You could make similar estimates for the US and the wider globe. So clearly a disorder that we need to do something about. But as well as there being a problem with the treatment, there's a major treatment gap. So we have effective treatments, whether that's talking therapies like cognitive behavior therapy, or it's antidepressants, medication. I mean, there's very good standard comparative parallel randomized controlled trials showing that those do better than placebo, they do better than waiting list. But even there, with our best treatments, we're probably only getting about a third of patients to full recovery and remission. And of those who do get better, about 50% will have a further episode within the next so many years. So definitely scope to improve our treatments. We also have issues about availability. The majority of people in the world are not treated or do not receive evidence-based treatment. And there's also a question about the scalability of a lot of our treatments. So if you think about the traditional face-to-face talking therapy model, where you get together with a therapist in a room and you schedule a session, there's clearly a limit to how many of those you can give, because there's a limit to how many therapists there are and how many sessions they can schedule. And I mean, it's worth noting in the UK, for example, we've really tried to expand our treatment provision. We've had this IAPT, Improving Access to Psychological Therapy service, which is now in the whole of England. So you can get referred by your GP, or you can self-refer to get a talking therapy for anxiety or depression. And even with that being rolled out, we reckon about 15 to 20% of the people who need treatment are accessing treatment in terms of an evidence-based talking therapy. And that's probably the best that there is anywhere in the globe. And if you move to lower and middle income countries, we're dropping down to under 5% of people are being able to access treatments. And then the third issue about our treatment gap is making sure that our treatments are actually acceptable, that people want to use them and will stick with them. So I'm going to be thinking a bit about effectiveness and availability in terms of how we move forwards from here. So there's always been this question of, well, how do we actually improve treatment? And broadly, there's sort of two approaches that I think we can take. One is the sort of old traditional approach, which I think we can still get mileage out of, and indeed we'll come back to this as the talk goes on, which is by understanding and targeting pathological mechanisms. So if we can understand the causes or the maintaining factors in a disorder, and then we can find better ways of targeting them, that ought to improve outcomes. So that requires some mechanistic understanding of the disorder. But we could also try and get a better understanding of actually how the therapy works, because that's not always clear. And indeed, in the field of mental health, it's particularly unclear. So there's been raging debates about how antidepressants work. And it's very clear that every 10 years, the prevailing model turns out to be wrong. A new model needs to be generated because it doesn't fit the data. So the idea that people are low on neurotransmitters and they need to boost their neurotransmitters is clearly a massive oversimplification. But that's also true of psychological therapies, our talking therapies. We've got lots of evidence that cognitive behavior therapy works, but we don't really know how it works. And so this was a paper that came out in Nature a few years ago that made that argument, that we need to understand these things. And there may be this argument that our efficacy hasn't improved that much because we either don't understand the mechanisms of the disorder or we don't understand the mechanisms of treatment. So it's got better in anxiety. Some of our treatments for anxiety have improved over the last decades, but you could actually look at our psychological interventions for depression, and you could look over the last 50 years, and if you look at the basic effect size, there's a bit of bouncing around here and there, but on average, the effect size across trials hasn't really changed, which is pretty staggering when you think that, you know, we've got an effective treatment, but it hasn't really got better for that long. And that could be because we don't really know how it works. So we don't know what we should be focusing on, what we should be taking out, what we should be putting in. So the whole issue of, you know, what are the active ingredients and how do we optimize the treatment going forwards? That seems really critically important in the field of treatment of mental health. So this is why when I started coming across Linda's work and the concept of optimizing treatments, I thought, oh, you know, this seems like a really obvious place to try and think about it, because we just don't know this stuff. So we don't know what treatment components have the biggest effect on which outcome. And it's worth bearing in mind in mental health, we may be looking at multiple outcomes. So there's a lot of comorbidity. So someone who's got depression may also have anxiety, and it might be that one thing's better for one and another thing's better for another. So who responds best? What are the active mechanisms? What aspects of therapy do patients actually want to engage with? Now, they may not be the same thing. We hope that they are, but they may not be. So our goal is really to try and build a stronger, more potent, simpler, so that increases ability to make it accessible if we can narrow down the treatment components so that it's easier to train and disseminate, briefer for cost effectiveness reasons therapy, in an evidence-based way. And I know Linda can talk to this about when you're doing optimization, you can select which of those criteria you're really working to and how you're judging against them. But if we put those all out there, and then we can see where we go to. So it might be that we can't really make the therapy more potent than it already is, but we might be able to make it simpler and briefer, which would still be an advance. But if we could make it more potent, that would be great as well. So when we think about therapy for depression, particularly talking therapies, just as sort of a bit of a background, there's this debate about common versus specific factors, which goes back to the 1950s, the 1960s. So there's really great. I've actually got it on my desk. Didn't think I was this prepared, but sort of a classic book is Persuasion and Healing by the Franks, going back to the 70s, which a lot of this stuff starts from and hasn't really been resolved since. So the argument that, and this is particularly the case for depression, that people are getting better because they're having therapy, and in that therapy, they're working with a nice, supportive, understanding therapist, and that therapeutic relationship in its own right is helpful and making them feel good, making them more motivated. Or it could be the therapy itself is just giving them some structure. It has some rituals in it that are helping them think about things differently. They're getting hope, or in the Frank terms, they're getting remoralized to go ahead and do things. And all of these could apply across different treatments or different elements of treatment, and therefore would be what we might consider non-specific. Then there might be more specific mechanisms that relate to the specific theories and potentially the specific procedures of an intervention. So in cognitive therapy, we'd spend a lot of time looking at changing behavior. So people are depressed, are doing less. Can we build up their activity, get them more in touch with rewarding, reinforcing activities? Does that improve their mood? Or can we change their cognition? So thought challenging, cognitive restructuring. We know that in depression, people might have a tendency to be thinking in a more negative way. Can we, when we train them to be more positive or to look at things in a more realistic way, does that help? And there's some evidence for those specific factors in experimental studies, but not so much in clinical trials. And there was a very nice review by Pim Kuipers and his team back in 2018, where they kind of weighed up the evidence for, well, can we say whether it's common or specific factors? And they basically said, no, we can't really separate them, because none of the studies that have been done using an appropriate methodology or an appropriate sample size or appropriate controls to actually distinguish any of these things. So it's a big gap. And this kind of will be interesting when we come to the results of what we've done, because different people might interpret it as pro or cons, some of these different arguments. And this will be stuff that will be familiar to a lot of you. So, a standard clinical trial, which is the kind of stuff that the parallel comparative trial that we've been doing in a lot of medicine and psychology and psychiatry, and this is what a lot of the trials of treatments for depression have done, can really only tell us if the overall treatment package is better than its comparison. So is the CBT package as good as or better than antidepressants, and is that as good as or better than pill placebo or some other control? So the issue is that all the treatment components in that package are aggregated and confounded together in the comparison. So we can't actually, so basically it's a horse race, hence the picture, that doesn't tell us very much about what's going on inside. And then the other thing is, a lot of the data that's tried to unpack mechanism in this space has really focused on people doing a trial and then putting some measures in and trying to do mediational analysis. But that tends to be limited because the mediations are still somewhat indirect and correlational, because they're only looking at the whole treatment package. So you can't tell whether you're specifically manipulating a particular factor. And it's possible given a lot of the mediators in psychology, at least, tend to be interlinked. You could give someone a treatment to change cognition, but that might also change behavior. And then it gets very hard to work out what's going on. Okay, good. I'm trying to find a way to see what I'm doing. So again, this is probably stuff you all know, but the idea is that, in the Factorial trial, we can allocate patients by chance to different combinations of treatment components. So we can reveal which factors have the biggest effects. And this is another way of trying to engineer what might be going on inside the treatment. And I guess this is coming back to Linda's comment earlier about how do we educate people about this. I've kind of got a picture from engineering for one set of audience, but also when I'm talking to psychologists, I basically say we do this all the time in experimental psychology. The 2x2 factorial experiment is kind of what every undergraduate sees. But when we say, oh, we're going to do by a 2x2 trial, people go, what? What's going on? But conceptually, same thing really, just different level of logistics. So that was the argument, and of course there are different factors, maybe easier or harder to manipulate. So one of the there are studies now there's been a few published where everyone gets the treatment, but then they might manipulate things around the mode of delivery. So you might have factors that are about are you getting guidance support or not getting support? Is it what level of support are you getting? Is it delivered through the internet or is it delivered face to face? Those kinds of things. So the basic treatment stays the same, but the delivery mechanisms around it might change, or the structure might change. Now that's important and useful information to help decide how we might improve treatments, but it doesn't tell us anything about what's happening underneath the hood of the actual treatment. So again, maybe super familiar to everyone. I mean, the advantages of the factorial approach are we can directly test individual components and their interactions, which we can't do for a standard parallel trial. We can manipulate potentially hypothesized mechanisms and examine individual mediators if we get a factor that actually is more closely linked to a particular mediator. Potentially, I think this gives us an opportunity to do a better job of distinguishing specific versus common treatment factors, because in aggregate, when we're comparing one factor, the high level versus a low level of a factor, it should be that everything else is the same between them. So a lot of the problems of previous studies where they've looked at specific versus common factors is they're just not very well matched. So a lot of the studies, for example, have taken an evidence-based treatment and then they compare it to a control that is a very weak attentional control, and often doesn't have the same kind of plausibility of rationale, doesn't have the same structural elements in terms of the number of sessions or the contact with the therapist. So when you compare those, it's really not a fair comparison to say, oh, this treatment did better than that, and therefore it's a non-specific effect, because you haven't really matched out. It's a specific effect because you haven't really matched out the common effects. And my argument was, well, if we're doing a factorial and everything else is equal, then the difference will be the specific component rather than anything else, which means it's a bit more complicated, and we'll get to this, but it's a way of parsing out some of the element that it might be common or non-specific treatment factors. And I won't go into the maths of all of this, but you're all familiar with the idea that they're efficient and economical for power and sample size, in the sense that we don't have to keep running multiple people and multiple trials, and the same people contribute to the different comparisons within the factorial. So this is probably a slightly out of date graph chart of the most approach, but I mean, I guess what we were coming from is we can identify what we think might go into the treatment package, and I'll say a bit about that from the literature of CBT in a minute, and then we want to run this component selection experiment as our first factorial, and then possibly refine, and then if we think we've got something better, go to a full large-scale trial. And I guess we haven't progressed through these later steps with the data I've just talked about yet, partly because it's only come out recently. But this might be the goal when we come to the Wellcome project, is if we get some good evidence that we think we can assemble a stronger beta intervention to go back and say, now can we do the proper test against the standard therapy? And I think we might get a reasonably receptive audience, because the whole point of this exercise is to come up with a better therapy, and you can't tell it's a better therapy unless you do a control comparison against what's now seen as the current gold standard at some level. Okay, so we published a trial protocol in BMC Psychiatry in 2016, and as you can see, Linda and John were involved in helping us with this trial protocol, but I put pictures of Lexi and Michelle, who are the two postdocs who did a lot of the work on actually recruiting and following up patients. And like a lot of clinical trials, I don't know if this is true in other fields, but in psychiatry, we seem to have to come up with these snappy anagram acronyms for our studies. So this was improve, implementing multifactorial psychotherapy research in online virtual environments. I don't think I'm going to come up with a better one than that, so I may as well just stop now. And it was 2 because we did a little pilot before we did this, just to check we could actually make it all work. So what we thought about is we went back to the literature and we go, what do we know is in cognitive behavior therapy, and what might be the things that are really important to look at or not look at. And this was partly based on kind of precedent of what people have published. There's been some Delphi studies of what people consider to be the core ingredients. There's also been some theoretical work on what people see as the core ingredients. And then there's also been some recent, in the last 10 years, suggestions about some new things that might work to improve the intervention. So what we try to do is identify factors that we could clearly argue, yes, this is part of what people would recognize in core cognitive behavior therapy for depression, in terms of procedures that people parse the therapy into, that we could then look at in terms of our analysis. But we also want to put some novel ones in case some of the things that have been emerging might actually have added value and haven't been tested. So I think the obvious ones that most people would recognize are activity scheduling, so building up positive activities or not building up positive activities. That's a very strong element in the cognitive behavioral literature. Indeed, most models talk about that. There's also thought challenging cognitive restructuring, so helping people to identify negative thoughts and come up with plausible alternatives or look at the evidence for those. Those would be key. Relaxation comes up in a few packages, though there is some more recent evidence that it may be less effective. We might come back to that. Functional analysis is another behavioral activation element. So if activity scheduling is about building up, doing positive things, functional analysis is about understanding the patterns of behavior, triggers to behavior, trying to build better plans, look at contingencies, and reduce avoidance. So there are versions of behavioral activation that are used for depression, some of which are purely activity scheduling, and some have both activity scheduling and functional analysis. And then we have on the bottom line 3 new interventions that we've been generating. So there's a lot of work in the field about self-compassion, people talking about how the importance of helping people to spot self-critical thinking and approach that from a more supportive, empathic, kind perspective. And so we thought that'd be interesting to put in, given it's talked about a lot, but there's not a lot of strong trial evidence. Concreteness training is something we've used in our own work as an intervention, and we've got evidence as a single component that it was effective. So it seemed like a good one to fold back in. So this is basically teaching people with depression to be more specific about their description of situations and events, and particularly negative ones. Because what we find is there's a general tendency for people who are depressed to get quite global and abstract and overgeneral. So one bad thing happens, and that means something else bad is going to happen, and that means the world's out to get me, and I'm going to fail at this, and then I'm failing at everything, and then I'm a complete failure, and it just spirals out. So if we can train people to stay to the context of a situation, go, oh, that's just the one thing that happened. I made a mistake, but it's that mistake, and it was in that situation. It doesn't go broader than that. We've got some evidence that's helpful. And then the other thing we did was absorption, which is really based on this idea that one of the key theories of tackling depression is getting people in contact with positive reinforcers, so they're getting rewarding and positive experiences. And you can do that by activity scheduling. So you basically try and build up the frequency of doing positive things. But our clinical experience has told us that sometimes people do positive things, but they don't get the benefit from it. And if you look at what's happening, it's because they're not really in the event as they're doing it. They're distracted, they're ruminating about something else, they've got a running commentary about how this is much harder than it used to be, or they're not doing it as well as somebody else. So they don't get the benefits. The idea of absorption is, can we get people into the experience of what they're doing when they're doing something positive? So those are the 7 factors. So we could justify all of those based on the wider literature, Delphi, what people are reporting. Pretty much everyone would agree that activity scheduling, functional analysis, and thought challenging should be in a CBT treatment for depression. The other ones are a bit more novel. I guess the one thing we didn't have was problem solving, but that was that would be maybe a factor too many. Though the concreteness training is shown to improve problem solving. So we've got these 7 factors, and what we're interested in is comparing the presence or absence of them, with each present 50% of the time, absent 50% of the time, and then sort of orthogonal balanced design, so that we can aggregate the main effect across all the cells. So that would be fairly familiar. So, so there's a kind of a breakdown of our factorial design, and it's a fractional factorial design because obviously with 7 cells, if we had all of the combinations full factorial, it would be many more cells required. And the main reason, 2 main reasons for being fractional were, one, that the logistics of having fewer cells, but the other reason was to because we wanted to do this in a clinical setting, and therefore we didn't want to have that. We wanted to make sure we didn't have a cell where everything was low or none. We needed to give everyone some kind of intervention, which allowed us. So a fractional design allowed us to do that. And then you can see this, how it's broken down a bit more. These are just showing, the fact that here we've got people who received activity scheduling and the different combinations that they got, and then the people who didn't get activity scheduling and the different combinations. And so you can see that they're balanced and they're orthogonal in the design and the way that it's laid out. So I probably don't need to labor those. And similarly for thought challenging and absorption and so forth. Just to illustrate that there are different combinations for different cells. So we recruited patients in the NHS and people who self-referred to Facebook adverts from the community, and they had to have depression as determined by having caseness, so above a threshold on the Patient Health Questionnaire 9, which is the most common measure, and they were randomized to one of these 32 variants of an internet CBT. So I haven't said why we did internet CBT, but I guess there were 2 reasons for that. One, that's coming back to the scalability question. How do we get therapy out to more people? CBT internet version might be that. But the other reason from a research perspective is that we've got much stricter control of the elements in an internet therapy, because we can control what modules people see or don't see, so that if we say they're supposed to be getting absorption or not getting absorption, we can make sure that happens. Whereas if we were doing this purely in a face-to-face therapy, I think it'd be really hard to stop some therapists from sliding across and introducing other things and getting that kind of drift. So the way that they all had support from a therapist, in the UK, we have this psychological wellbeing practitioner who's a low-intensity therapist who's had training in this kind of online support, is asynchronous. So people would go through a module and then they'd get feedback later written that they could respond to. And as I said, everyone received treatment, so there's no treatment or waiting list control. So we could run this in an NHS service, so we could get real world patients. And the other thing that we did is we had a welcome module right at the beginning that everyone had to complete, which is basically a bit of simple psychoeducation and an introduction to what the therapy might involve, because we've seen a lot of attrition in internet therapy. So we wanted to see if someone, before we randomize them, that they could actually get that first thing done, and that therefore we're not losing so many folks as we go forwards. Though we still lost a reasonable number of folks, as you'll see. So we had a follow-up at 3 months, post-randomization at 6 months later, with our primary outcome depression on the PHQ-9, but we also looked at secondary outcomes on anxiety, GAD-7, brooding, work social adjustment scale, which is measuring functioning. And then we've got a bunch of self-report process measures in there, which I'm not going to talk about because we're still tidying that up for the mediational analysis. And also, we lost some of the data. Less of those were completed because we focused on getting our primary and secondary outcomes. So in the end, we managed to randomize 767 patients with depression, so not a small sample. And we managed to get 65% of them completing our follow-up assessments at 9 months, which is not bad for an online. It's not great, but it's not terrible for an online study, particularly with people with depression. And this might be a bit too small to see, but here's basically the consort flow diagram. So you can see how many people we had to screen in and out, how many people we reached out to at the beginning, and how they came in from different places. So we had quite a few. We had more coming from the online screener than from the clinical service, which may not be surprising on the basis that for it to come from the clinical service, somebody in the service had to assess someone who was coming through the service and then decide, oh, this might be a good thing. And so it's an extra step in their treatment process, whereas people coming through the online, they just came straight through. And you can see we excluded a decent number of people. A bunch of people were eligible, but not everyone chose to participate. And then they got randomized and then followed up over time. And broadly, this sample was not atypical for what we might expect for people with depression. So in their mid to late 30s, predominantly female, about 40% were single, about half were in full-time work. A reasonable number were, over half were using antidepressants. Nearly 96% had a previous treatment. We've got an average of about 5 prior episodes of major depression. So this is a recurrent group, and they've got quite high levels of severity coming in. So, one of the criticisms that we got from when the paper was being reviewed was, oh yeah, this wasn't a normal sample of people with depression. I'm going, yeah, this is a normal sample of people with depression, at least as they present in the NHS in the UK. They're not any milder than the normal clinical. If anything, they're a bit more severe than their normal clinical presentation. So, okay, so this was published in JAMA Psychiatry. So we managed to get the grant, the study completed, and we've published it in JAMA. So if you want to look at it, JAMA Psychiatry, if you want to look at it in more detail, that's the paper. And I maybe talk a bit about the process of that, because I know that we've been trying to get the Factorial studies out in reasonably good outlets, and I'm quite pleased to get it into JAMA Psychiatry because that's quite a high impact journal for the field. And it was kind of an interesting review process. So let's just go through what we found. So I guess the first thing to say is we just looked at everyone changing over time, and this is what we're basically finding is we're getting reasonably good clinical outcomes. So you can see the PHQ scores going down over time for the whole sample, the GAD scores going down.
Ed, can I interrupt you for a second? Could you please, for those of us who are not clinical psychologists, could you please explain caseness?
Yeah, okay. So caseness would mean that they're meeting criteria that we think they've got a significant level of symptoms for depression. Now, it's slightly different from a diagnosis, because obviously a diagnosis will require somebody to go through a diagnostic interview of some kind. And we did some of those for this sample. I'm just not reporting them here. But the reason I'm reporting caseness is because this helps us to compare it to what's happening in the clinical settings, particularly the NHS, because in our talking therapy services, in our improving access to psychological therapy service, so that's what IAP stands for, they measure caseness for what people going through their services normally. So they can comment on how many people are meeting caseness and how many people are coming out of caseness on the criteria. And the criteria for the PHQ-9 is that you have any score of 10 or above is in caseness. So if you're dropping below 10, you're getting out of caseness. So they would typically take patients whose score is 10 or above for the service. And what this says here is that they're typically finding that about half of their sample is reaching caseness, is coming out of caseness. This is what they're defining as recovery. So what we're getting is actually slightly better rates than that. We're getting so everyone met caseness at baseline because that was a criteria to come into the study. And at 3 months, 61% didn't meet caseness anymore. So we're getting, I guess the point of this is to illustrate, on average, before we even break it down by factors, the people in receiving the aggregated treatments are doing okay. In fact, it's doing as well as the standard treatment in the NHS. And it looks like it's maintaining itself over 6-month follow-up. And it's also not differing between whether they were getting the treatment through the clinical service or through us recruiting in the internet and providing the service ourselves, the treatment ourselves. So that's what this slide is really about. It's like saying we were getting decent outcomes here and they're comparable with what is happening in the NHS. And it doesn't differ by site. Does that make sense?
Yeah, thank you.
And obviously this is before we break it down and start looking at factors, but it seems important to do that, because if we're not getting a reasonable treatment effect, it's like, well, okay, at all, then maybe the factors don't matter. So this is just to show the numbers in each of the levels, and it's basically to confirm that we're pretty close to 50% in each, either in high or low or yes or no for each of the components. So this is the main analysis, which is our baseline score adjusted ANCOVA model for change in PHQ from post-treatment to 6 months. And I mean, I haven't highlighted the top line, which is fairly predictable, which is if you're looking at a subsequent depression score, the biggest predictor of that subsequent depression score is going to be the baseline score. I mean, that's just sort of given. But then can we show any effects above that? And what you can see here is that there's nothing significantly happening for our main effects and our selected 2x2 interactions. And of course, we only had selected 2x2 interactions because it was a fractional design and we therefore could only choose to test some of them. And even these are all confounded with higher level factors, which is something maybe to come back to. But we didn't get much at the post-treatment, but at the 9 months, so the longer term follow-up, we were getting a significant effect where having absorption training versus not having absorption training reduced PHQ-9, and there's an interaction where having the interaction between self-compassion and activity scheduling was also reducing PHQ-9. So you can interpret this in lots of different ways, and we'll come back to that. But we've got at least a signal of something happening, and it's only happening at the later time point of follow-up, which is not inconsistent when we look at treatment effects for therapies. Often you get more of a treatment effect later on because people sometimes might be having more practice to take the effects forwards. But everything else was basically a non-significant. Those are the only two significant things. So we've got a main effect and an interaction. And this is another way of just showing some of those things. So here are the graphs for the presence or absence of each of the main factors across time. And what you can see is, we're getting the same effect where everyone seems to be improving from baseline to post-treatment, and then it's stabilizing over 6 months. And there's no difference between the presence or absence of each of those factors, except on this absorption condition where it looks like having absorption is having a benefit over time relative to not having absorption. Oops. And the other thing just to note is because this is a sequential, we had people doing these modules in order, so we had to counterbalance the order of the modules, and that might be something to think about in future designs. So basically each component was given people as the way we did it in the internet therapy is that you get a module which would introduce that component. So you might get a module that introduces you to thought challenging, and it'll have several elements. So talk about how to spot negative thoughts, then how to challenge negative thoughts. And then the next week you'll get a different module. But we built it in so that each module would be re-brought up. So if you'd already had thought challenging, every subsequent module would kind of say, how are you getting on with the thought challenging? Have you practiced it over the last week? How's it going? So make another plan with it. So it's trying to keep it going across subsequent weeks whilst bringing in the new information. Of course, what we know is that there's going to be attrition as people work through a treatment package. So if we put the same module, if we had a consistent order of modules so that you always did activity scheduling first and thought challenging last, then we're going to have far few people doing the thought challenging. So what we did is we also randomized and counterbalance the order of the modules so that they were balanced across the conditions. So, but that adds a bit more complexity. But what that means is that broadly, people only did about people who got randomized to a module, to the high level of a module. Only about half of them actually did it because they either didn't engage with, they didn't work that far through the therapy, or they didn't follow up on it. So we're reducing our dosage effect there, and that's why we've also looked at doing a case analysis, looking at how whether they did comply with completing it adjusts the outcomes. And basically, the short answer is that when we do that kind of analysis, it doesn't make any difference. I mean, the one thing that still comes out as significant is absorption, and everything else is still non-significant. So I guess that's reassuring that it holds up with those two analyses. So, I mean, the one kind of takeaway finding, I mean, there's several takeaway findings. If people ask me, what do I take away from this study? There's several things I could say. So one is I could say, well, it looks like there might be some value in looking at this absorption thing a bit more, because it's having a small effect on depression, but a significant one. And it's adding something to the value of the overall treatment package, which when you've got these quite complex multiple part treatment packages, and I'll come to the kind of constant component across them as well, the fact that you can get anything having an effect on that might actually be quite meaningful. And what that really suggests is that, the absorption training plus all other specific modules plus the common factors is doing better than the absence of absorption plus all the other modules plus all the common factors and the core components. So that might indicate there's something there. And what it's really doing is trying to improve this direct connection with experience. So it fits a wider piece of literature that's suggesting that the behavioral activation element might be particularly important in tackling depression. But what we're doing here is we're not getting people to do more positive things. We're making sure that when they do positive things, they're more likely to get the benefit of those positive things. Because it's got things like visualization exercises about trying to get into a frame of mind where you can be immersed in what you're doing rather than distracted. It uses some of the concepts and ideas from the flow literature. We're scheduling not just positive activities, but actually absorbing activities. So it might be a slight tweak to CBT that has benefit, though, of course, only one study with its limitations. I think we'd like to see replication before we were confident that this was something that might be useful. But it's at least conceptually consistent with what we might think would be helpful. So I guess one conclusion is that there might be a single specific treatment effect, and so if we believe that, that's quite a good thing in the sense that we can say it's not all just common non-specific treatment effects, because finding any specific effect means it's not all due to common effects. Though I think it gets more complicated, because if we think about the constant component of these treatments, what we have to think about is that all of these treatments have a number of things, all of the arms, whether they've got the presence or absence of a particular factor, have a number of things in common. They all have support from a therapist. They all have self-monitoring. They all have a certain level of structure. They all have the idea of making plans between sessions and following them through. And they all are giving people a new strategy to try. And it might be that those elements in their own right, going back to the Frank and Frank kind of work, are actually quite effective in depression, because, oh, someone's supporting me, someone's giving me something good to do, I'm trying something new, it makes sense. That's common to all of these factors, and that might in itself be why it's quite hard to get an effect of specific techniques. That's one possibility we need to think about. I mean, the other thing, of course, is that all of these elements are CBT common. So you could say that they've got CBT specific common factors rather than PANS therapy common factors. I mean, some things will overlap. The idea of hope and structure might overlap between different therapies, but some of the things in here might be specific to CBT, or not every therapy So there's a CBT kind of rationale across all of these, all of the as a core component. So that's that. So some people might come back and go, "Oh, you really didn't get a specific effect. So this is all about non-specific factors." And I would go, "Well, we can't conclude that from this study. At best, we can conclude that the common factors across CBT might be quite important. But the only way we could really test that is to have another trial where the factors varied, factors that were common to CBT and common to other psychological therapies, like IPT, for example. But that's one element. I guess there's a question of, did we have too low a dosage? Only half of people were doing the interventions that were complex. It's also weakened by, potentially weakened by the fact that we've got this fractional design. So we've got these confounds, aliased factors. So it's not as clean cut as if it was a straight full factorial. And as I've said, depression might be particularly sensitive to giving people a sense of increased control, remoralization, trying out new behaviors, which is common to every one of these interventions. So it's, you could argue this either way. And certainly some reviewers were going, well, how do you know that anything's going on here? But, I think the point we were making is, well, it's worth looking at this as a model of how we might further unpack it. And obviously then you might need further studies to take that forwards. So I think it's interesting that we did get something on absorption. I think it is telling us that we do need to think about this constant component. There might be interesting to do future studies where we break down the things that are quite different between, you introduce variability that's different between different types of therapy. So there are some therapies that don't do homework. They don't make plans with people. They just talk about stuff with people. And if you could compare that might help to unpack some of these things. The other thing is that it might be that there are mechanisms that are important that cut across the procedures that are typically identified in CBT. So if we think about behavioral activation as a procedure, because it's about building up positive behavior, and thought challenging as a procedure, and the idea is that it's working on the mechanism of changing cognition. That might be too oversimplistic. It might be that there are underlying mechanisms that are common to both of those, which is why it's hard to unpack them, because the way we've carved the joint here, it follows procedurally what people typically do and how people have talked about therapy, but it may not actually reflect the underlying reality of the mechanisms. So to give you an example, and I'll come back to this, I mentioned this idea of specificity in depression. Well, it's actually really hard to do a lot of these interventions without doing something that might push people to be more specific. So if you think about, we had an intervention that was about training people to be more specific about depressed events, but we also had thought challenging. And when you do thought challenging, you ask people to describe a specific event. And the more they get to talk about the detail of that event, the more chance they have of looking at alternatives. And when you get people to make activity plans, when you do them properly, as you ask people to make plans that say, what are you going to do? When are you going to do it? How are you going to do it? What are the steps? So that all of those things, you could argue, have an underlying process of making people more specific. But we haven't. So you could say, well, it's hard for us to disentangle those because there's a different level of analysis here that we have that doesn't match the modeling of core ideas in therapy. So it might be that if we really wanted to do a factorial in therapy, we would try and manipulate some of those more underlying factors, and that would require us doing slightly different. We couldn't just take off the shelf components. We'd actually have to take a component and then, okay, we're going to give you thought challenging, but we're going to give you a version of that where we don't get you to be very specific, and we give you a version where you are more specific, for example. So these are just some thoughts that have been coming out of this, and you'll see how they'll feed into the next study. So hold on, okay. Right, okay, good. So that's what we've done. Let me tell you a little bit about what we're planning to do, and hopefully the logic of that will be kind of sensible. So one of the things that we see a lot in depression is what I call repetitive negative thought. So this is rumination, brooding, overthinking, worry. And the idea is this is might be a mechanism we want to target because we see it as a transdiagnostic risk factor. So people who overthink and worry are more likely to be anxious and depressed. It helps to account for that comorbidity. It's also something we see as a common pathway in the risk of development of anxiety and depression. So we know that, for example, having difficult early life events, having recent stress, having a family history of depression, having a personal history of depression, having certain types of personalities, such as more neurotic personalities, all predict increased risk of depression. They all also predict increased risk of worry and rumination. And statistically, if you factor out the worry and rumination, that mediates quite a lot of that relationship. And of course, things like early life events, your own family history, your own personal history, your personality are things that are pretty hard to change. But maybe if we can change your way of thinking, that's more tractable. So that's the argument for why we might target repetitive negative thought. And it also emerges at the point where we see depression and anxiety really lifting up in adolescence. And we also know that CBT treatments do reduce worry and rumination. They don't do it brilliantly, but they do it a bit. And when we see that it does reduce, we see a greater change in anxiety and depression during the course of treatment. And when it doesn't change, repetitive negative thought tends not to change it. So it kind of, for all these reasons, it felt like it was a really good target to go for. And this is the other thing that I've been doing lots of research on. And then coming back to what do we do for taking this forwards in terms of understanding therapy? I mean, it occurred to me that one of the problems with depression is that we know that people temporarily can get better from depression to lots of different things because of this idea that they might get hope, they might get control, which might make depression quite a hard thing to pull out factors that differentiate. Whereas we know that actually it's really quite hard to change people out of repetitive thought because it's more of a habit. And we know we've got some more evidence that there are some interventions work better and other interventions don't work so well on this. So that made me think, well, maybe this, if we're trying to distinguish active ingredients of therapy, this might be a better target than just symptoms of depression, because it's less likely to move just because someone had something that was plausible and convincing, and those kinds of things that we just talked about. We also have an intervention, a CBT package that we know works on treating rumination and worry, which I've developed and successfully shown it works in full-scale trials. But what's interesting is we can break that package down by processes, but we can also break it down by mechanism, because we've got some theories of how it might work. And so this is what we've been thinking about is, there might be these different elements that might cut across different procedures in therapy that we want to try and manipulate as mechanisms, and then that might make it tighter for us manipulating those components across the therapy. So I've talked about the idea of specific descriptions and shifting thinking style as one. We've talked about it being a habit, so there might be specific habit change things that we can put in or out of the therapy to make it more effective. Talked about self-compassion, which is particularly linked to rumination. And then there's attention training, which is partly mindfulness. I saw there's a question about mindfulness, but it's also part of what we were finding in absorption, of getting people in the present moment focus of what they were doing.
Ed, excuse me, I just need to interrupt you. We only have about 3 minutes left in our session, so I just wanted to.
Oh, sorry, I didn't realize I was taking so long.
Yeah.
So I've literally on the last slide, which is basically what we're going to do is take this and put this into a factorial to then see which of these mechanisms and components might help change rumination, but also because we're going to build in measures for them, we'll have a better chance of actually testing the specific mediators through that process. So this is an illustration of what we might do. And what we're going to spend the first part of the grant is actually narrowing down which of these factors we want to put in. So we're going to do a lot more experimental and lived experience work. So we get these factors as strong as we possibly can before we put them in the factorial. Oh, sorry, I've taken too long.
Oh, no, that was very interesting.
Yeah, thank you so much. Maybe if we do have a minute, we can turn to the question that was in the chat about how similar absorption therapy is to mindfulness training. I know you were just touching on that a little bit.
Yeah, I mean, I think there's similarities and differences. So they both involve being in the task, present moment, and attentional focus. I think the key difference is that often mindfulness is an exercise that people do where they're stepping away from things. So they're watching their thoughts or they're watching their breath. Whereas when we're doing absorption, it's about being in a task. So it's not about stepping back. It's about stepping in to something. Though, of course, you can do mindfulness activities. So that it depends on your definition of mindfulness. I guess in terms of the intensiveness of the treatment, I mean, it was typically running over about 8 to 10 weeks of people trying to work through the modules. So the idea is they'd log on, spend a couple of hours on a module, they'd get a therapy responding to them, and we try and keep them working through and practicing those elements. So again, pretty typical of how internet CBT for depression would be delivered.
Great. I guess we're about at time. Yeah, we probably shouldn't take the last 30 seconds for another question, right?
Yeah,
so we'll say thank you again for this wonderful talk today, and thank you to everyone for being here. Do we have a slide for our next?
I just like to say, I hope when you've completed that study, we can have you back, because we'll be very, very interested in.
Well, I'll be talking to you about it as we go along, I think, hopefully, Linda.
Yes, yeah, I know, because I'm involved in it, so I'll be able to keep an eye on it.
Great. Thanks very much.
There we go.
Thanks, Ed.
Thank you, Ed.
Yeah, it's lovely to see
Really
you.
great to see you.
Bye,
care.
everyone. Thank you.
Bye, Molly. Thanks.
Bye, Molly.
Bye. Thanks, everyone. Thanks, Ed.
Bye.
Thanks,
you.
everybody. Bye.